This is Mayo Clinic Talks, a curated weekly podcast for physicians and healthcare providers. I'm John Wilkinson, a family physician at Mayo Clinic in Rochester, Minnesota, and I'm stepping in for Daryl this week. Just 2 hours ago, the CD said it's not so much a question of if, it's a question of when. We are asking all American people to prepare for the expectation that this might be bad. They're talking about the coronavirus outbreak. I'm delighted we can talk with Dr. Pritish Tosh, a Mayo Clinic infectious disease specialist. Dr. Tosh came to us from the CDC, and he's also an expert on emergency preparedness, pandemic planning, and biodefense. I can guarantee you that there's nobody better suited to bring us up to speed on this developing story. Thanks for joining us today, Pritish.
Hey, thanks for having me.
So how worried do we need to be?
You know, I'm an eternal optimist, and for the last several weeks, I've been just looking at the case counts coming from China, and the last 2 weeks the counts have been coming down, but these last few days have been sobering, I think is the best word, in that now we're seeing these outcroppings of infection far away from China. And initially, a lot of these cases we were seeing, Singapore, there were somebody directly that we knew came from China and then from the outbreak area and sort of spreading, and you can contain those. At least we've been able to. The epidemic currently going on in Italy is a little more concerning in that I don't think we've identified an index case, somebody who was directly there in either Wuhan or something, came to that part of Italy and then subsequently spread it around. So without finding a clear index case that really suggests that there are these invisible chains of transmission from wherever this started to wherever it ends up. And if there are these invisible chains of transmission, that pretty much means it could be anywhere. So how worried am I? I used to be a lot less worried, but these last few days, I'm pretty concerned.
Let's back up for just a minute. Why China? Why the Far East? What is it about that part of the world that seems to be the origin of some of these emerging viruses?
I think people forget that the 2009 influenza pandemic came out of North America, Mexico, California, and back 1918, what was called the Spanish flu, probably came out of Kansas, and so we have our own fair share of things that have emerged from us. But the question about why always China? Why does it appear like these all come out of China? It's high population, and a lot of these emerging infections come from some sort of animal reservoir. If they were known human infections to begin with, we would have already known about them, pretty much. And so when you're introducing new viruses, often they're coming from some sort of reservoir. Animal reservoir is a really good one. And 2003, we saw SARS looking at the either civet cats or the badger dogs that were in these markets, so live animal markets in China, and that really seemed to have been potentially the source. Looking at other coronavirus infections, Middle East respiratory syndrome, it came in just a few years ago out of the Middle East, and that seems to be a coronavirus that mostly is in camels, but does infect people. And so it's whenever you have this close intersection between animals and people, that you start to develop these zoonotic diseases that come from animals into people and then potentially can spread from person to person.
Initially, this was referred to as a coronavirus or coronavirus infection. Now it's COVID-19.
Yeah.
Why the name change?
So there's a large number of different coronaviruses. Corona meaning crown, coronation, right? Crowning. But that's kind of what it looks like under electron microscope. It's got this crown around it. So there's a large number of different viruses. There's really been a lot of push not to name these things after the geographic region that they come from. is the New Delhi metallo-beta-lactamase. I think the folks in New Delhi were really not pleased about that one. And so rather than talking about this as the Wuhan coronavirus or Chinese novel coronavirus, just talking about this as a coronavirus disease that was emerged in 2019, so COVID-19.
You use the term epidemic. Some people have used the word pandemic. Help us understand what's the difference and what is this?
Yeah.
Now,
there's a lot of different terms that are thrown out, and some of the things kind of mean the same thing. So whether it's a cluster, an outbreak, or an epidemic, it kind of depends what kind of emotion you want somebody else to have. If it's in your own facility, it's a cluster. If it's somebody else's problem, it's an epidemic. But yeah, they kind of mean the same thing. And there's different uses of pandemic that others will use, and there's official ones by WHO, and they may have been, maybe other people are using different things, but the concept is the same. That this is something that's no longer geographically contained, that it has the potential to be more broad, potentially the entire world. Now, whether that means everybody in the entire world is at risk, or it has the potential to cause localized outbreaks anywhere in the world, there are nuances of that term. But for this virus, it certainly has a pandemic potential, meaning it could certainly cause outbreaks throughout the world, whether this means community infections where everyone in the world is potentially at risk, versus outcroppings of outbreaks like we're seeing in Italy right now. That remains to be seen. I'm worried about the former.
So how is this different from previous outbreaks? Is there something unique about this virus or its transmission?
Yeah. When you're looking at the SARS coronavirus from 2003, that after we controlled the outbreak, it pretty much disappeared. We got rid of the zoonotic reservoir from these markets, and you never heard from it again. You look at something like Middle East respiratory syndrome, MERS, that's become somewhat endemic, especially amongst young camels in the Middle East. Other things such as avian influenza, you see cropping up every once in a while. Often those will go away and then reemerge. But this one is different. It doesn't seem like it's going to go away easily. And part of this is how easily it's transmitted from person to person. It would appear that it's much easier to transmit from person to person than pretty much any of those other viruses I had mentioned. It's probably not as easy as influenza, but we're kind of talking that same ballpark. Going back to 2009, influenza pandemic, H1N1 influenza pandemic 2009, within a week of finding the virus in Mexico, California, it was elsewhere in the world. And within a month, it was community infections with this novel virus were common throughout the world. And so this is spreading a little more slowly than that, in that we're not seeing community infection in the United States after a good 6 weeks of really intense activity in China. Looks like it's been going on for longer than that within China. But this slow march is really concerning. And it's possible that what we're seeing is a peak in China 2 weeks ago, and then you have with an incubation period up to 14 days. Maybe you're seeing a peak of sort of these small fires getting out internationally, and if you just put out all these fires, then maybe we can stop it. I wish that were the case, and there's a hint that we may still be there, but the chances that that's not going to happen is becoming increasingly high. And at this point, we need to prepare for a pandemic within the United States and try to shift our mode from thinking about taking care of one or two of these patients, if it were to come up, to really transforming and thinking about, well, how are we going to do this across the country?
You mentioned the incubation period. Compare that with, say, influenza, and also how contagious are people during the incubation period?
So that the latter question remains to be seen, and it would appear that some people can transmit before they're really symptomatic. How much of transmission occurs before people are sick? That's something I don't think we know very well yet. It would appear that most people are going to transmit while they're sick. Comparing that to influenza, people are certainly transmitting before they get sick, which is kind of why with an influenza epidemic, you can't stop those. You can just try to manage them. I think the world has done the best we can in trying to stop the onslaught of this infection. The nature of the virus makes it really hard. And again, there's still this glimmer of hope that maybe this is just 2 incubation periods away from the peak, and if we can just put out all these fires, maybe we can dampen this. But I'm an optimistic guy, but I think the facts are staring us in the face that's unlikely.
So we should be preparing. First, what should we as healthcare providers be thinking about and doing? And then next, what should we as citizens be thinking about? Healthcare providers first.
I think we've learned a lot, and it's been a steep learning curve. It would look that if you're looking at the patients who are taken care of within the United States, including in community hospitals, without subsequent transmission to healthcare workers, this is not special training. There's no special equipment. Using the CDC guidance, putting patients in negative air rooms, wearing appropriate PPE, some sort of respirator, N95 or a PAPR, some sort of mask, face protection, gloves and gown, you can prevent transmission. And that's been done at regular healthcare facilities throughout the country. And so this is something that can be done by healthcare providers reliably and safely. In terms of citizens, anytime you have an epidemic, the first thing that comes up are the really sick cases. Those are the ones that make the news. Frankly, a 19-year-old who has a sniffle is not going to get written about, and a 90-year-old who dies of pneumonia, unfortunately, is also not going to make the news. And so it's when you start to see these relatively healthy people developing severe illness that people start to take notice, and of course those are the ones that make the news. Looking at large numbers of these cases, it would appear that most people, especially healthy people, have mild illness with this infection. The case fatality, people would say mortality, but the case fatality as we're seeing is in that 2% range, probably closer to 1% when we start to really factor in how many asymptomatic and minimally symptomatic people there are potentially with this infection. And so in comparison, the 2009 influenza pandemic, probably 0.5% around that range, case fatality. And so this is something that's probably going to be a little worse than a influenza pandemic, at least the last one we had, but kind of along those lines. If you imagine a severe influenza year, we might be looking at that sort of range if this becomes a community infection within the United States.
Heard talk about quarantining and the isolating people, and by and large it doesn't work. But what practical precautions should we be taking in our offices and in the outpatient setting?
The first thing we need to do is also remember that influenza is actually really high activity right now. And if somebody hasn't gotten influenza vaccination, they should do so, because that's actually the virus that is circulating in the United States right now. Thinking about COVID-19 and not getting your flu shot is unacceptable. And so do what you can, to prevent the thing we already know is circulating. The next thing is you're working within your healthcare institution to get a sense of what the plans are going to be, and recognizing that there may be a time that this becomes a community infection, and we may be called upon to take care of these patients. And it would appear that we have the knowledge, we have the ability to take care of these patients safely.
Hand washing, number one thing to do?
Yeah, hand washing, respiratory etiquette, these are important, right? Don't sneeze on people. It seems crazy to say that, right? But sneeze into the crook of your arm. If you feel like you have a fever and a respiratory illness, don't go out, right? Stay home. Social distancing. Wash your hands. And these are the simple things. Staying healthy. It would look as though the people who are having the worst outcomes from this novel coronavirus are those you would expect to have poor outcomes from influenza. And so the healthier you can stay, the healthier you will be after potentially getting this infection.
Talk about don't go out and staying home from work. It seems like people don't stay home long enough or often enough.
Yeah, I think we have a lot of social pressures, especially in healthcare, to come to work. Like, oh, I'm just gonna do it, right? I'm not gonna let my colleagues pick up my slack. It's a problem we call, rather than absenteeism, it's presenteeism. And across the board, it's better to stay home. It only makes things worse. It may make you feel a little better at the time that you're doing your thing, you're doing your part, but in the end, it's actually backfiring and causing more harm, because then one of your colleagues is next.
Could I just come to work and wear one of those masks?
Don't do that. If you're sick, stay at home.
Thank you. I keep hearing that this might affect the whole global economy. How does that work?
I'm not an economist. One of my concerns, and we may start seeing this already, is supply chain vulnerability. And usually when I talk about supply chain vulnerability, mind you, I can do that for hours. It's usually met by snoozes. But now people are paying attention. We have no idea what medical products are made in Wuhan, or what medications, primary pharmaceutical ingredient is made in certain parts. In fact, during Hurricane Maria, we found out that all of these IV fluids were being made in Puerto Rico, and suddenly there's a hurricane, and we had shortages. That is in our backyard, and a U.S. territory. And so our understanding of the supply chain of things sourced out of China, put that in perspective. And so my expectation is, now we're about a month out from the real start of this thing, and the just-in-time inventories that we have to sort of maintain within healthcare to make the margins make sense. Those will start to be taxed, and then we're about to find out what kinds of products are made there, and it's probably going to hurt.
Well, thank you very much. You have any last thoughts for our listeners?
This is an evolving situation. The tone coming out of CDC, from World Health Organization, has changed dramatically in just the last week. I'm an optimistic guy, but the facts are staring me in the face. I remain hopeful that this could be we just got to put out these small fires. But we really need to prepare that this could be something that becomes a community infection, including the United States. And as healthcare workers, we've got to be ready for it and be confident in knowing that the steps we can do can protect you. They've already worked in healthcare facilities in the United States, just like the one you're at, right? Whoever you are. And so I think that's kind of my parting word.
We've been talking about COVID-19 with Dr. Pritish Tosh. Thank you for your time, Pritish. And as Daryl says, if you enjoyed Mayo Clinic Talks, please subscribe. Stay healthy, stay hopeful, even if you can't stay optimistic. We'll see you next week.